last speaker of the day is Dr. Aaron Wong. So he is a nuclear medicine physician and radiologist here at Peter MacCallum Cancer Centre. Thanks, Aaron.
Congratulations on making it this far. So I'm Aaron, and I'm a radiologist and nuclear medicine specialist at Peter Mac, and I've been given the impossible task of talking about AI applications in PET CT in 10 minutes, so good luck. But given the broad audience, I want to set expectations that this will be a general talk. The promise of AI is that it will scale access to expertise and reduce cost across the whole patient journey. And the best way to approach it is to think about it from the jobs to be done framework in healthcare. So to tackle this elephant, let's approach it in chunks. And I want to limit the talk today to just the quadrant of professional-facing clinical applications in specialist AI. So as we go through this talk, I want you to think about the great challenge of standardization and reproducibility. And I hope by the end, we can have a common framework to talk about how AI can be used in cancer imaging and theranostics, how can we assess the level of evidence for AI and where are we now, and what challenges face AI implementation. So AI can help in each step of the cancer imaging process, and we can break it down into its parts. So from the patient to the image, or image generation, that involves acquiring, reconstructing, and image enhancement. From the image to the patient, that's about deriving actionable information that can impact patient care. Clinical workflow is how the system runs efficiently or otherwise. And finally, unique to radiopharmaceutical therapies is the aspects of drug discovery and dosimetry. PET is still inherently a semi-quantitative study type, and standardization of image generation is crucial, but beyond the scope for this talk. And so to really make it quantitative, we really do have to do that standardization. But today I want to focus on that image-to-patient applications. And I'll be breaking down into just sort of basic steps and things like detection, quantification, lesion tracking, and reporting, and briefly touch on dosimetry. In PET, we're really trying to answer the question, is it hot or not? And then, is it disease? So segmentation is also then about drawing a line around the tumor and answering where is the border of the tumor. And segmentation can be done with absolute or relative thresholds or completely manually contoured. At Peter Mac, with the PSMA PET CTs, we use a absolute threshold of 3 for our contouring. And in this example study, they did actually manually contouring by imaging experts as the ground truth. So already there's a difference. AI was trained on this study, and then to assess performance, they looked at the patient level, then the lesion level, and finally at the voxel level. And they were giving patient level accuracy of around 83%, lesion level detection with F1 scores around 93 to 97%, but at the voxel level, they're only getting the DICE coefficient scores around 65 to 70%. So really that segmentation is still a challenge. And combining CT with PET helps us with clinical localization. Similarly, then, for these automated algorithms, segmenting out the normal organ in CT allows us to compare that then with the automated tumor localization on the PET scan. And this is a result from an older publication in 2022 using the PROMISE criteria for PET and showed an automated algorithm sensitivity of lesion detection and localization of over 87%. The result of that was actually PROMISE or Pylarify AI, which is an FDA-cleared product for automated assessment in PSMA PET. However, like many other early CAD or computer-assisted diagnostic systems, there's a criticism of high number of false positives. And there was actually 19.5 false positive pelvic lesions per patient in the study. So, there's other solutions. There's a more open and free solution by the Scandinavian group called Recomia. This can be accessed with request. And this one focused just on pelvic node detection and achieved better with around 1.8 false positives per patient. That seems lower, but actually when you looked at the between doctors, the false positive rate was 0.3. So that's really the practical number to beat. Ultimately, segmentation will probably be semi-automated, and assuming segmentation has been done accurately, the next step in the AI pipeline is about quantification and radiomics. So quantification, we've heard from James about metabolic tumor volume SUV mean. SUV mean for PSMA over 10 has been associated with better outcomes. And radiomics really is about extracting further quantification features that are beyond the naked eye. And to improve reproducibility, I would at least include the Image Biomarker Standardization Initiative, and that has over 174 radiomic features. So using radiomics may help as a discovery tool for relevant features, and it can be useful to assist with deep learning AI explainability via ablation studies. However, the challenge is one of statistics. As the study goes, lies, damn lies, and statistics. And so the challenge is ultimately about external validation of whatever we find. And, because throwing the kitchen sink, you're going to find something that sticks. In this study, they showed, interestingly, that sphericity, or here they call it circularity, was associated with predicting disease in a PSMA avid lesion, but we already know clinically that tumor grows in balls. As a radiologist, I already conduct lesion tracking for clinical trials via RECIST. It's time-consuming, and for example, in modified RECIST, we provide only up to 5 measurable lesions. If you really wanted to track every lesion, it has to be automated. And this is a picture from the AIQ system, which registers lesions relative to their normal contoured skeleton to achieve lesion tracking. And in this way, they can systematically analyze whether the lesion is stable, responding, or progressive. This is an example in sodium fluoride PET, but the system has also been applied to PSMA PET. Use of AI is not just limited to images, but can be also applied to text. And we know that reporting errors are a bugbear that can slow down care and require clarification. And spell check has its limits. In this study, text-based models like GPT-4 demonstrated high accuracy and detecting clinically significant errors in radiology reports with F1 scores over 87%. And this can be clinically useful for reducing those errors. Interestingly, also large language models have been used to look at the content of the report as well to classify the patient outcome. And this is an example. It's in lymphoma, not in prostate cancer, and focuses on the lymphoma Deauville score classification. But what we can see is probably there'll be similar applications in prostate cancer to look for report discrepancies. And this example is interesting because it also introduces the idea about multimodal models, ones that can use both vision and language that are actually more effective in this task. Unfortunately, Lachlan hasn't been able to come today. I was hoping on him to supply that bit about AI dosimetry. But ultimately here, AI might be helpful in simplifying what might otherwise be a complicated process requiring extensive expertise. Moving forward, we need to move beyond these technical steps and focus on actually the clinical task and subtasks applied to the specific prostate cancer patient journey. And we need to standardize these clinical tasks and subtasks because this will help us construct the sorts of trials we need to gather appropriate evidence. And so now we move into part 2, which is how can we assess the level of evidence for AI and what is it currently at? Really, I would adopt this 4-tier model. And where we are at is at proof of concept evaluation and also just entering into technical evaluation. But we are not yet at clinical evaluation, really. And answering the question how these tools combine with the clinician decision-making process to impact patient outcomes, that still remains to be seen. And to design these trials, first we would use that, identify the appropriate tier, and then we would define that clinical subtask. And then report on the patient population to avoid cumulative bias down the track. And then from those, you can determine an appropriate figure of merit for this claim. Now, this particular paper and that link, I highly recommend, and the supplement is worth looking at because it really is comprehensive and lists out those figures of merit. So with only better evidence and trials can we hope to practically bring AI into the clinical setting. Finally, number 3, what challenges face AI implementation? Well, ultimately, we need an ecosystem to create trustworthy AI. Privacy, security, safety are standard requirements. But however, multiple parties are required when we want to tackle things like transparency, bias awareness, and fairness. And we need to create these robust trials to show that AI solutions are generable. However, we also then need to deliver that solution at the local level to unlock the promise of individualized patient care. So shifting trends in AI can show the path forward, and the speed of innovation is rapidly increasing already, particularly in the consumer space. And I believe that can give us some ideas and inspire us ways of applying AI in cancer imaging and prostate cancer care. Importantly, things and trends like foundational models like GPT and ChatGPT show that you can perform new tasks now with single-shot or few-shot training. There's multimodality models that combine vision and text. There's the use of the AI co-pilot, where you can streamline simple tasks. There's ideas about, and these tools are continually learning and require post-deployment monitoring. And finally, there's the idea of low and no-code tools, which can help an individual clinician customize their care. So thank you for listening. I hope that now you have a common framework for continuing these discussions in AI. This is a technology that will affect everyone and everything. And AI won't replace doctors, but doctors that use AI will replace those that don't. Thank you very much.